Okay, well, let's get started. Hi, everyone. Welcome. Thank you for joining this workshop. I'm really excited to be here with you this morning. The workshop is on real-world data for real impact, advancing breast cancer monitoring and care through Rebecca. And my name is Alexis Strader. I'm the Director of Policy and Research at the European Health Management Association. So before we begin, I just want to give a few reminders to you all, our participants for today's session. We want this to be an interactive workshop, so we look forward to your participation as much as possible. If you have questions, we welcome you to put those in the chat or hold those until the end when we will have Q&A from the audience. And this session will be recorded, so just keep that in mind. We're going to be using the session and the recording for communication and dissemination purposes for the Rebecca project. And lastly, if you have any technical difficulties, please feel free to reach out to the Emma team by using the chat function, and one of my colleagues will assist you. So with that, I'd like to quickly go over our agenda for today so you know what you have in store. First, we will have a presentation from Yanis Serafis, who is a project coordinator for the Rebecca project. And then after his presentation, we will hear from health authorities from three health authorities and their perspectives on Yanis's presentation. We originally were going to have four, but one of the presenters unfortunately wasn't able to make it this morning. So we will have Mr. Marco Di Donato, Dr. Javier Michelena, and Dr. Michael Pielsen, who will give their perspectives. And then once they've done that, we will move into an interactive discussion. I'll moderate this part with some questions, but we will also turn it over to participants to ask your questions. And we hope that it'll be an interesting and engaging dialogue. After that, we will use the last few minutes of this workshop just to summarize and wrap up. So with that, Ali, if you could go to the next slide, I will quickly introduce Yanis Serafis. Yanis is a machine learning researcher and the technical manager of the EU-funded Rebecca project, where he coordinates the project's scientific and technical work. He's from the Department of Electrical and Computer Engineering at Aristotle University of Thessaloniki, and has experience in research projects with a focus on medical and behavioral monitoring. So with that, I will turn it over to you, Yanis. Thank you.
Thank you very much, Alexis. So I will give you a brief overview of the Rebecca system, mostly on the Rebecca monitoring tools, also the data we collect, and some of the digital biomarkers we are able to extract. So, very briefly, the Rebecca concept has two main pillars. The first one is on clinical research. Here, we want to collect real-world data in order to understand the impact that treatments have on the quality of life of the patients. The other pillar is on patient management. Here, we want to use real-world data in order to improve care choices and personalize the interventions for individual patients. So, what happens now? So, after the patient ends her cancer treatment, she is typically assessed every 6 months. We argue that this is infrequent and subjective, especially when it comes to the prompts that we collect with standardized questionnaires. Also, the consultation sessions typically are pre-scheduled and may not match the needs of the patient. Instead, what we propose is that we use continuous monitoring for the patient's well-being, including functional and emotional status, in order to provide a more holistic and objective overview of the patient's quality of life. To achieve this, we use real-world data, and using this data, we are able to extract new indicators and digital biomarkers for the patient status. At the heart of our monitoring system, it's the Becca 660. This collects data from electronic health records, wearable devices, mobile apps, the online behavior of the patient, and environment data. All these data are then aggregated in order to achieve some comprehensive patient profiles. Now, I will go through the system. The first element of the system is the patient app. Through this app, the patients are able to collect some self-reported data like photos, for example, meals, drinks, and some environment parameters, stressors, or things that make them happy. We are able to integrate, secondly, with the Garmin wearable. Through this, we collect very deep insights regarding physical activity of the patient, sleep, heart rate, stress, and also using our algorithms, we are able to have some automatic meal detection. Also, the app has functionality for short prom-style questionnaires. And the app also is able to continuously track the location of the patient in the background. We can use this information to identify any changes, for example, in the mobility patterns of the patient, which may reflect some changes in her functional status. The patient app also has some light feedback mechanism to improve the engagement of the patient with the app. For example, she can see the patient, the steps, and the active calories burned through the app. In addition to the patient app, we have a secondary app, which is the companion app. Here we have a different type of user, the companion, which can be a spouse, a friend, or a child, or anyone else that the patient assigns. These companions answer periodically some questionnaires about the patient for her status. And so we can use their provided input as an additional source, a data source for the patient, a more objective, let's say, if we can say that data source for the patient. The Becca 360 also has a browser plugin that is for Chrome browsers, which can monitor URLs visited, search queries, and social media interactions like likes, retweets, etc. And also provides some feedback to the patient. These are two examples on the right for the topics that she commonly visits, and also the emotions. The most prevalent, for example, is the bottom right graph is the most prevalent emotion per day that was detected through her online activity. All this information is then consolidated into a clinical dashboard, which presents an overview day by day of the indicators we extracted, the digital biomarkers. In this picture, you can see the daily indicators we have extracted from the Garmin wearable. For example, we have the steps, distance walked, the calories burned, the heart rate, and the wear time for the watch. Also, the dashboard can be used in order to provide some timely support for the patient. For example, here we have a column that for certain patients, we have some warnings, and in order to inspect their data and maybe see if we need to provide them some extra feedback and extra guidance. So, and this is actually one of the ways you can use it in patient care for actionable feedback and some early warning flags. This is an example of the patient steps. We can monitor the trends, the levels of your steps, and if we detect a period that a prolonged period with low steps, then this could raise a flag that, like the one shown above. Another way to use it in patient care is that combining them with some guidelines, very detailed guidelines we have created for patient guidance. So these are 2 pages from our guidelines. The one is for diet, and the other one is for physical activity. These have been created using the references from national and international guidelines on managing lifestyle for cancer patients. And what we have attempted here to do is that we map these recommendations to specific measurable indicators that can be verified in the clinical dashboard. So the idea here is that the doctor or the nurse can go through the dashboard, to see the data and sit with the patient and see this checklist of possible recommendations and see which apply uh, uh, to her. Moving on, we also use this data, this rich data we collect in research. In Rebecca, we are aiming for causal analysis of the data. And as part of this effort, we have created some causal graphs, like the one you see here. This is specifically was created for cancer-related fatigue. And what we could do here is that we replace certain nodes of this graph, and instead of steps and reports, use the objective data from the monitoring. For example, the sleep quality, the daily steps, the time the patient spent out of home, things like this. So we can have some more accurate and objective data in our analysis. Another interesting thing we have found in our collected data is that many of the indicators we are able to extract are very correlated with the physical functioning scores of the patients. Here in these graphs, you can see some indicators we have extracted from the Garmin wearable, and these are the steps entropy, the per minute steps entropy, the sedentary percentage of the patient, the heart rate to walking speed ratio, the daily steps per day, the maximum heart rate, and the maximum heart rate to resting heart rate ratio. And these are very correlated with the prompts that we collect through standardized questionnaires. And we take this one step further, and we use these indicators to create models that are able to predict the ground truth value that the patient will provide through the standardized questionnaire. And we propose that we use these digital biomarkers as a way to have some continuous estimation of the prompt surrogates. For example, in this graph, this is for one patient. We have prompts that have been collected for 3 times during her participation in the study. Typically, these are collected every 5 to 6 months. And using our models, we are able to have a continuous estimation of this functioning score. And it is very interesting that we have very accurate predictions compared to the sparse ground truth we have from the standardized questionnaire, and that we are able to fill in the gaps in the months between the evaluations. So, as you realized, all this was not hypothetical. We have run our studies and have collected a lot of data that we are in the process of analyzing. So far we have conducted 2 observation studies for breast cancer-related fatigue in Norway and osteopenia osteoporosis in Spain, and for male and one feasibility study for male patients for prostate cancer patients in Norway. And we have also evaluated Rebecca in 3 intervention studies as a tool for support for patients. So here compare standard care and patients that receive standard care plus the Rebecca assisted interventions. And we have 3 such studies conducted in Sweden, Norway, and Spain. Of course, we are very much interested if we have any other possible application or domains that we can scale and expand. We would like very much to hear from our experts and also the audience. That would be very interesting. So I don't know, Alexis, if we have time for questions and clarification now, but yeah, I leave it to you.
Great. Thank you very much, Yanis. I really appreciate it. And in terms of questions, I mean, when we move to the interventions from our health authorities, they certainly may ask you some questions, so don't go anywhere. I would like to keep you around, and because I'm sure that there may be some follow-up or need for clarification on a few points. So Thank you again for your intervention and for sharing more on Rebecca 360. And wow, really impressive work, very innovative, and really excited to have a discussion in here from our health authorities. So today we have four gentlemen who will be giving their perspectives. I'd like to start, we'll go in alphabetical order, if that's okay, with first hearing from Marco Di Donato. He is the Policy and Project Manager at Euriga, the Brussels-based network of European regional and local health authorities, uniting 27 members across 17 countries. He supports the coordination of Euriga's working group on cancer, fostering collaboration among regional experts to exchange knowledge and best practices. Marco also contributes to EU-funded projects on cancer under Horizon Europe and EU for Health, including OncoDear, PrediLynch, and YARN. He holds a master's degree in international relations and diplomatic affairs from the University of Bologna with a specialization in EU studies. So, Marco, the floor is yours.
Thank you very much, Alexis. I hope you can hear me well, everybody. Good morning. First of all, thanks for having me. Thanks for the invitation, and congratulations to the Rebecca team for the excellent work presented. The presentation was quite impressive, and it's always encouraging to see such an ambitious efforts to combine, clinical outcomes, real-world data into one digital tool. At Euriga, which, as Alexis already anticipated, is a network of regional local health authorities, cancer is one of our key priorities because, as you may know, in many countries in Europe, regions have responsibilities in the delivery of healthcare services and strong competencies also in prevention, including in cancer. So we look at cancer in a very holistic way, from the health promotion prevention side to the survivorship. And so we strongly welcome tools that can support this holistic, broader perspective as Rebecca has put forward so far. I'm not a digital expert myself. I'm not an informatic or a healthcare professional, but what strikes me in Rebecca 360 after the presentation is its patient-centered approach directed to the value to the patients. I think that's very important because you look beyond the clinical trials and hospital records to include the quality of life and lifestyle factors. And this is exactly what health systems need, because health outcomes are shaped by daily life as much as by the medical treatment. And the project itself is very interesting for us at Euriga, also because we are involved in another cancer mission project, OncoDear is the name, which is focused on the primary prevention of colorectal cancer, and which has as its own aims, like pretty much similar approach. Like the project aims to develop AI-powered tool based on recommendations direct to citizens through collection of data from the citizen, including lifestyle, for example, and then a platform dedicated to clinicians to build on those data, give recommendation, validate recommendation, the risk level detected by the app, and then all flows into another, let's say, layer of digital tool, which goes to policymakers for improving policy. So I see a lot of commonalities in terms of the approach and the vision and the objective to pursue, and so it was very interesting for me to see how the platform was developed, and I think there is a lot to learn from each other also, because if I'm not mistaken, the coordinator of the Rebecca is also part of the OncoDear project, so it would be great to further exchange on this. And learn, especially also like the engagement strategy you used for the citizens, because I mean we know that we had a lot of discussion internally also in the consortium to how to ensure that the patients are, let's say, keeping in engaging in the process, in reporting data and so on and so forth. So I would be very interested if that could count as a question from myself on how, if the project had some particular engagement strategy with the citizens to learn from. By the way, I mean, I really appreciated the multidimensional data, the approach that the app has. Also because, I mean, combining all these factors, we can get a fuller picture and design more personalized and integrated interventions. And here, I will just touch quickly upon a point before giving back to you the floor, Alexis, because I mean, when it comes to integrated care models, I would like to stress two factors that are very interesting for us as a network of regional authorities. The first is the behavioral and cultural insights that are equally important to the other data. So gathering contextual data to taking into account, I mean, cultural habits, accessibility, but also the capacity of health professionals. So taking into consideration not only the citizens, but also the health professional. And then, I mean, as a representative of a network of local authorities, I think that going local is always key because in neighborhoods, for example, and there it comes to the neighborhood analysis as well. I mean, you can collect real world data and understand the conditions in which people live. And that's very important when it comes to the whole pathway, of care, from prevention to survivorship. So yeah, I would stop here, Alexis. This was my first reaction to the presentation. Thank you very much again for having us today, and looking forward to continue this discussion.
Thanks so much, Marco. I really appreciate it, and I appreciate you kicking us off in terms of initial thoughts and feedback. What I heard from you, and what were many things, but what especially stuck out to me was the importance of a patient-centered approach and integrated care models that take into consideration the behavioral and cultural aspects. I think that's really important to highlight right from the very beginning, and something that was very well done in the Rebecca project, and is something that is important for the best outcomes and for patients. So I appreciate that, and of course going local, which we definitely like to hear. So with that, I'm going to move on to our next health authority. This is Dr. Javier Michelena. Dr. Michelena is a rheumatologist and clinical informatician with a PhD from the University of Barcelona and University of Leeds. He also holds a master's in data science and AI from the University of Alcalá. He trained in rheumatology and spent 2 years at the Leeds Institute of Rheumatic and Musculoskeletal Diseases, where he combined patient care with research on spondyloarthritis. At Hospital Vall d'Hebron, he practiced as a rheumatologist and A&E physician, later joining the IT department to lead digital health and AI initiatives. In 2024, he became head of clinical informatics at CatSalut, shaping Catalonia's digital health strategy. So I turn it over to you, Javier.
Thank you, Alexis. Thank you for having me in this very informative session. For me, as now being the clinical informatics lead, that we have this mission in the Catalan Health Service of redesigning, I would say, the national EHR. So we started last year with some participatory process to gather what were the needs of the professionals, of the patients, and I was very positively surprised listening to Ioannis that they also that you've also incorporated the caregivers. I think that was a very nice addition, having this companion app. This is something that we've already acknowledged that in some type of patients, the caregivers probably are even more important than the patient when it comes to deciding what are the pathways, what are the management strategies. So I would put the focus on that. Some of my thoughts have already been said by Marco. I think one of the positive point of this project is the focus on the different type of data incorporated in the different models. This has already been said by Marco, and I will also stress the need of incorporating the environmental data that you haven't touched upon that much in the presentation, but I saw it in the slides, and I think this is relevant because now this is a very important health determinant, and it's also related to what Marco said about the neighborhoods and etc. Because this probably is even more important than the management pathways or therapeutics that we give to patients. So sometimes the impact that changing some of these determinants can make is even more relevant than what we can decide as healthcare professionals when giving a treatment. Also, I really like the PROM surrogate. That was insightful, like finding how things that are passive, so that wearables are collecting, can give you information about the prompts. And I will give an example that it's quite illustrative of this. In here in Catalonia, we deployed a NEPROM system across all the region, so all the citizens are able to answer prompts in their own personal health app. But what we've seen is that the engagement is very low, and it requires a lot of effort of the healthcare professionals to do the prompts with the patient when they come to the clinic. So we haven't been that successful in people being able to report their prompts from home. So having this surrogate in certain specific patient might be helpful, because we know there's this digital breach that not all patients are that familiar with reporting data in applications. And also, to end my intervention, I mean, I've seen this has been done in breast cancer or in cancer, but the outcomes that the project leaders selected are quite broad, I would say, and it's easy to implement this in different diseases. So I haven't seen anything that is very specific to cancer. So this gives us the opportunity to apply it to other diseases. Also, because we are moving from a disease-centric healthcare management to a more multi-morbid or multidisciplinary approach. So also when it comes to guidelines, that this was mentioned. So now we are used to having guidelines for every disease, but at the end, these are interrelated. So having these digital platforms that can be agnostic of disease can help us tackle and change the way we think and the health policies are shaped when it comes to delivering healthcare to these patients. And I'll leave it here for now.
Thank you very much, Javier, for giving your perspective. I really appreciate it. And, I think what you said about the companion app and including caregivers being so important, and something that really stuck out to you did to me as well. And I also liked your thoughts on the prom surrogates, because this is really insightful for us to understand how we can better collect these data, because indeed we tend to face issues with being able to consistently gather data from patients, and HCPs often have to prompt patients. There's that digital breach, of course, that you mentioned. So maybe this is a learning that could be applied in other areas, which and even this tool could be, as you said, implementable for other diseases or disease agnostic, I think you said. So I think some of the points you raised, I have a feeling will also will spark some conversation with our next speaker, Dr. Pjolsen, but I don't want to spoil it, so I'll let him take it away from here. But first, let me introduce him briefly. So Dr. Michael Pjolsen is the International Coordinator and Program Officer at the Swedish eHealth Agency. He holds a PhD in Medical Social Sciences, an MSc in Biomedical Engineering, and a BSc in Nursing. His career spans academia, research, and innovation clusters with a focus on digital health. At the Swedish eHealth Agency, he leads work in the EU Joint Action towards the European Health Data Space 2, or TEDAS 2, as you may have heard of it, and has long experience in international benchmarking of national digital health strategies. He is also part of the core group on policy environment in the Global Digital Health Partnership and contributed to the WHO's Europe Regional Digital Health Action Plan 2023 to 2030. Michael, the floor is yours.
Thank you, Alexis, and thank you for inviting me to this important session. And first, again, I would like to thank you for creating this platform, extremely useful and with extreme value for putting the patient in front of their own trajectory or journey, so to speak. As we speak previously, thank you for these wise comments also from my colleagues here in the panel, because it brings me really back to my previous life when I was working at a rehabilitation clinic at the university level with chronic pain patients. And we asked ourselves what are the important questions to put to our patient to understand their journey. In this case, there were patients with not too much physiological signs. There are many emotional distress and all these blends of different kinds of symptoms and findings and non-findings put them into a very tricky situation when it comes to be treated in a medical context. So we asked ourselves, how can we understand these patients? And what we did was that we used all these questionnaires that we asked our patients. It was some kind of 300-400 questions, and we put them into one database, and then we used, it is not AI technology, but related mathematical technologies to find those symptoms that was most important for a specific trajectory. And what we came up with was that for these patients, it was not actually the pain that was the main problem. It was depression, anxiety, and that kind of distress that was most predictive to life satisfaction. And that was kind of an eye-opening for me at that time, what this kind of monitoring could be used for. Because in Sweden we have, in a clinical budget, it's around 98% going to reactive medicine, just 2% to preventive medicine. And what is between preventive and reactive medicine? It's predictive medicine. And that is where your platform fits in my mind, looking into the predictive markers that could be used as a precursor of a specific patient symptom journey, or perhaps also a patient clinical journey. And perhaps these could be blended in this kind of tools if they are used in a good way. So self-reports is an underestimated tool when it is added to other clinical markers or indicators, so to speak. So what I see in this this work is, it's it's a tool for identifying frail conditions, actually. And what are these indicators or markers to identify these frail conditions? It could be, if I'm an asthmatic, you show us just that you have environmental markers. So perhaps the particles in the air could be a marker for a frail condition in an asthmatic patient, or if a cancer patient just coming out from the hospital and have a quite frail condition for infections, etc., etc., etc. So that is my glasses I put on when I see what you have just presented to me, and it also brings me to, in my previous life I was in an innovation cluster, and they created this amazing gadget that was put on the sternum to identify different breathing markers and connected to the vascular markers as well. And you could predict the exhale frequency and how these changes due to medicines and vice versa in the COPD patients, for example. So I see a lot of connections here, and put it into another kind of work that have been used in my previous role at the health agency, comparing different kinds of national strategies for how to identify these important markers. One example comes from the Veterans Affairs in the US, who's serving approximately 9 million Americans, military personnel. And they have this app store to be used by the patient in their everyday life for different purposes, from mental illnesses to whatever they are suffering from. And they were coordinated by a nurse who was a practitioner nurse and had all these specialties around her. So that's another example from my previous life. In a Swedish context, we are at our agency now looking into a national digital infrastructure. And if we are doing this in a proper way, in the long run, it could be used for different kinds of service providers, adding on their specific platforms into a national context. That is my wishful thinking. We already have a kind of this because in Sweden, it's, as you know, it's really fragmented in the state. We have not the responsibility for the healthcare, but the regions and the municipalities. And they are independent from the state in that sense that they are politically elected, and they do their own way of providing care in different regions, although they collaborate, of course. But from that kind of challenge, we see that how can we use these wonderful tools that you have provided in a clinical context? How can we use it so it can to the benefit of the patients, and perhaps for the patients that are not patients anymore, they are turning from the patient perspective into the ordinary person, and vice versa in different phases of frailty, so to speak. So I leave for this. That is my reading of what you have been telling me in this first part of the session. So thank you again for having me, and thank you for all the wise things you have shared with me here.
Thank you very much, Michael, for sharing your perspective. A lot there to comment on, and that I think it really gives us a lot of food for the next section in our discussion. But you know, I liked where you were talking about how these emotional indicators, the emotional distress was really what was most predictive to patient outcomes, the depression, the anxiety that they were experiencing more than anything else. I also really liked how you situated the Rebecca 360 tool in the predictive space that sits between preventive and reactive, understanding that the majority of the health interventions we currently have in our health systems are reactive. So we need to go more towards the preventive side. And then, talking about your experience specifically in the Swedish context, a fragmented system where a tool like this could really benefit patients and for different service providers. So thank you very much for that. And I think we'll speak more on that momentarily. We have a fourth health authority in the room with us. I want to see if Professor Gabrielli is available to provide his insights as well. Are you on the line, Professor Gabrielli, and would you like to share your thoughts?
Thank you so much. Good morning, everyone. Thank you for the invitation and congratulations to my colleagues in the Rebecca team. I'm a physician, and I'm going to contribute to this discussion by introducing some reflections on the evolution that has taken place in medicine over the last 20 years, more or less, regarding the use of digital data originating from medical and healthcare activities as a whole. Can I share 2 or 3 slides? I can, I suppose, yeah? I try, eh? I will try. I'm going to try.
Absolutely, Professor Gabriele. If you'd like to share slides, you're welcome.
Okay. Can you see the first slide?
Yes, we can.
Yes, okay. Don't worry, it's just 3 slides, exactly 3 slides. Okay. And, let me say that it's very important to start by looking, speaking about the evolution of data management in medical activities and in the next medicine, next evolution of medical activities too. It's important for me looking at these 2 examples to the use of healthcare data with new digital tools to get a glimpse of the developments that we can expect to see in the next 5-10 years concerning on the use of digital technologies, of course. This is the first example. Is the research published in the 2023, in which the authors compare the cardiotoxicity risk in different kind of patients affected by different kind of cancers. The oncology patient were faced different kind of therapy, chemotherapy, radiation therapy, immunotherapy, and etc. And they use the artificial intelligence modeling to assess the risk of cardiovascular disease in these oncology patients. What is the importance of this work? The importance of this work is that is a brilliant example to use new digital sources, new digital technologies, and in this case, the machine learning and artificial intelligence, to try to use in another way, in a new, very new way, the clinical data that we collect from the patients. And I would like to underline to you that in the last 20 years, we have, we are living to now, nowadays, a revolution in medicine. We are the first generations that have in their availability the possibility to use digital technologies. These possibilities never existed before in the history of medicine. So to organize a new way, new perspectives in medicine, we cannot use the experience of other previous colleagues that in previous years work on the same, because they are not. They are not. So we have the first generations to face these new possibilities. And so we have to create a new method to work, new method for clinical experimentation of these technology and these new method in that. And we face also other problems. Let me show the next example. This is another work in which, and published in 2025, this year, and they in this work you can read the English version in the reference that you can at the bottom of the slide. Anyway, you face the show. I will just illustrate the figure at the right of the slide. The authors tested 52 different drugs, different active components, in order to test different combination between them. And they using artificial intelligence to perform this very complicated problem, and they at the end identified 496 different combinations with synergic actions of these drugs. And they at the end selected the best 30 combinations for these different three different teams in which they work. So in short,
Professor Gabriele, sorry, excuse me, sorry to interrupt, but we want to make sure to have enough time for our interactive discussion. May I ask if you to wrap up your initial intervention so we can move on to the next section, please?
Yes, just a conclusion. That's an example to understand what does it mean using, what are the difficulties that we have to face in order to manage in different way the data. And the last idea is to realize that we, speaking about digital medical data, we cannot we can use the different data coming from different sources, and that is a new issue originated from the characteristic of digital data too. Okay, that's I'm finished. Thank you for your attention.
Thank you very much, Professor Gabriele. I really appreciate it. And you know what I heard from you, that especially is that we're in a new era. So much has changed so quickly, but this is the first time where we're using these new digital tools in collecting this clinical data from patients. As we are the first generations, we need to be developing new methods and new approaches, and also understanding how we can manage the data from all these different sources in an ethical way. So I'm sure we will touch on this in our discussion. So I will thank you again and move on to some questions for you all, and also encouraging those participants in the audience, if you have questions for any of our health authority representatives, to please put those in the chat, and we will make sure that those are asked to the group. And if the question is directed to a specific person, please indicate that when you ask your question. So I thought you all are welcome to, any of you can answer these questions, but I have some that are specific. I'll direct them to a specific person, but anyone is welcome to comment or add on to what's been said. I definitely would like this to be a conversation. And of course, this is a workshop, so it's about learning from you all, hearing your perspectives, and your complementary expertise is really going to benefit us as we look to the future and the sustainability of the Rebecca 360 tool. So let's start off with looking at the clinical and technical perspective. Javier, I'm going to turn to you first because I'd like to hear from you. As you have heard Yannis's presentation, the other interventions, what comes to mind as some maybe concerns or obstacles that you foresee in implementing the Rebecca system into clinical workflows?
Yeah, thanks. Yeah, I think this is something that probably most of you will agree. Most of this type of studies, I would call them pilots, are then difficult to implement in real practice. And as Professor Gabriele said, yes, we are in a new era, but still, I was in clinic 6 months ago, and I was still visiting in the same way I did it 10 years ago or 20 years ago. Obviously, this type of changes are slow, and they normally start in research like this project, and then they get implemented. But I think now we are in a place where there are some things that can help the implementation. And when I was listening to Ioannis, I had some questions about, well, all this data, is this data being standardized using any interoperability standards? Now, we've got FHIR that is being really strong when it comes to messaging data from different platforms. Also, when you want to persist data from a more longitudinal perspective in the EHR, we've got OpenEHR, which is another standard that is gaining traction. So I think things that might help the success of this type of projects when it comes to implementing is all the data that is being generated to be persisted and stored in an interoperability standard. And also, it depends on what we are trying to achieve, but if we want this to be an integration of the HR, then we will also need some type of messaging integration that will help then the people from the IT department of the centers to be able to integrate. Then there's other things that are also gaining traction in the Nordics, and we will follow them, hopefully, which is this idea of the open platform. This was described in 2017 by the Aperta Foundation in the UK. You can find a nice paper about it. And the idea is basically to have a central repository of data when it comes to health data, and then having a middle layer which has some services that can be used by the different applications, and have and I think Michael already touched on that, having like this app store of different modules that then the health authorities and the hospitals and the primary care centers can use. So the idea is that the different systems, and this will vary depending on the implementation of the different countries. Some might be at a regional level, some might be at a national level, some might be more local. But in the end, is having this shared infrastructure that can be used by third party to develop their own applications there, so that then it facilitates the implementation. And this third party can be the industry, can be research centers, can even be professionals. Now, we are seeing that healthcare professionals are starting to develop their own applications because they know what are the needs. They see the needs every day, and they're starting to develop their own things or collaborating closely with the industry to build this application. So to me, as the first ideas I would share with the team would be, okay, looks very well. It's as we've said, it brings loads of benefits, but now we want to see this implemented. We want to see this in the clinic. So there are a few things like using standards and taking into account this open infra or architecture or this open infrastructure to then build this, have this plug and play feeling when it comes to building applications and developing applications, so that then the centers can implement them.
Xavier, thanks a lot. I just want to turn to the other panelists. Or Yanis, I know there was a question for you in terms of the data standardization. Anybody want to come in and comment here?
I think Magda has raised a hand. Should I go or
Please
maybe?
feel free, yeah.
Yes. Okay. So just to ask the question, you're right about the standardization. It's on the medical variables. This is easier because we had a lot of information directly from our partners, and we also had the common RedCap interface, and we collected EHR and connected this to the system. So we had already passed a very practice values that they already used in the hospitals. So this was already partly standardized. The other parts, for example, how do we measure certain environment variables? How do we measure the steps in it? We produce metadata for this, and for example, you can define, but I guess some things between manufacturers and between wearables are not as much standardized as we would like to be. That's you're absolutely correct. And I really like the other idea about as you and Michael said, about the said infrastructure, and that would be a dream for uh, opening this to many applications. Yeah. Maybe we open the floor to others?
Yes, thank you, Yanis. So, Michael, Marco, or Professor Gabrielli, any reflections or reactions to this first question? Otherwise, I see we have a participant who also wants to chime in. But oh yes, Michael, please go ahead.
Yeah, I totally agree. The interoperability questions are extremely important, especially when it comes to join different systems. And I think one of the challenges is that from a clinical point of view, there are so many systems and perhaps overwhelming as well, and yet another system could raise concerns. How will it be used? Does it work? Can we use the data in a qualitative manner for a specific clinical context and so forth? But I can stop there, and we can move on to other questions, perhaps. I see Magda has a hand, so.
Okay, thank you. Sure, let's hear from Magda. Thanks, Magda.
Yeah, thanks. No, I didn't want to interrupt this fantastic discussion. This was great, great presentation. Congratulations to all. Sure, I acknowledge that data and the interoperability of data is very important, but what I did not hear you refer to it is the transfer and take up. But like to see what type of process analysis you did and skills of human resources, because let's say if the technical part is okay, if we could fix that, we still need to see that if we transfer this to another hospital, and this is, I think, the EMA, no, the management is important here. How do we put it in different social context, and how do we skill how do we organize the transfer by seeing how does it work and what type of skills do we need and what type of redesign of processes we might need in order to realize the full potential. So I don't know who would like to answer that, but this is, I think, crucial in the uptake and the success of new applications.
Thanks very much, Magda. So what I'm hearing in your question is really the human resources aspect. It was a little bit of something that Marco touched on in his initial intervention, but I think any of the speakers may want to comment on this.
Not Alexis, not only in human resources, also the process design.
Yeah.
Do we need to redesign the processes? This is a managerial question, and the way how do I organize my whatever hospital or care processes.
Thanks for the clarification, Magda. I appreciate it.
Can tell you my opinion on this. Can I? Yeah.
Please go ahead.
I think that the most important. I think that the most important in this issue is to harmonize the interoperability of data and the interoperability of the workflow describing the work process in medical and clinical activities in general. Because of if you generate a data, interoperable data, but this generation, this origin of the data coming from medical, clinical activities quite different to each other, it's the same, it's impossible to compare in an objective way. The comparison will be not sufficient, will not satisfactory in the analysis of the work. That's my opinion. In Italy, we are facing this problem, this issue, and we are trying to solve them. We know in Italy we have several problems about this because our healthcare system is regionalized. So we have 20 different regional systems in data management, in data production, and etc. etc. It is not only a problem of standardization of data to transfer them from an hospital to another. Is to make sure that the workflow are comparable. Okay, thank you.
Thank you, Professor Gabrielli. And Marco, I see your hands raised. Please go ahead.
Yeah, thanks, Alexis. Actually, I mean, I wanted to react on what Professor Gabrielli just said, because, I mean, it really resonates with me working with regional authorities and having many members from Italy, and I'm Italian as well. So I really know, I know really well the situation there. But I mean, in general, we talking about barriers, because, I mean, we are talking about barriers right now. So for sure, I mean, we need to take into consideration that one of the barriers is the digital maturity of the different ecosystems. So, and especially, I mean, when it comes to regions and local authorities, you might have different, let's say, infrastructure, more or less advanced, depending, of course, on the resources of the region within the same country as well. So this is one of the main barriers. And beside this, we should take into consideration also the legal and regulatory framework, let's say, because health, for example, is a national competence. Data sometimes is regulated, most of the time is regulated at the national level. But I mean, we have EU legislation, we have regions that have their own interpretations of data. So this is something that also add, let's say, an added layer of complexities there. But I mean, if we want to turn this, let's say, barriers into enablers or into opportunities, let's say, because that's very important. And I think that if Rebecca say managed to do that, it could be like the winning point, because sometimes, as I mentioned, like regions have invested a lot of resources, authorities have invested a lot of resources in infrastructure, in governance models through which they also like organize the clinical settings, the interoperability between hospitals and healthcare facilities. So let's say the winning spot is finding, I mean, the way to make those solutions adaptable to the setting in which they might want and might go to operate. Because of course, one size fits all approach in never, let's say, pay back in terms of let's say the different realities we have in Europe. So I mean, if the platform, the tools that the project developed managed to like interact and become integrated into let's say systems in place, that for sure would ease a lot the implementation and the upscale of the platform itself. Of course, there's also a matter of resources from the national and regional level, but there, I mean, regions have resources to invest. And for resources, I don't really mean only money, but also like human resources, the upskilling and reskilling. We touched upon it. It's a very important issue, and it should go hand in hand with the implementation of the technical tools. And like having the regions, the regional authorities, the local authorities, this proximity to the local ecosystem, they really have an easy life, let's say, in detecting the needs. What are the needs? Also in terms of the skills needed by the professionals. So I think this is another component. And lastly, because I think we didn't touch upon it on this point so far, but I think it's very important. Trust. Because I mean, when we talk about the sharing of data, both clinical but also contextual data, like the one that we discussed today, I mean, having trust in the institution, in the hospital, in the healthcare system is key when it comes to turning a project into like then a working system, you know. So having governance model, clear communication, transparent communication system, and citizens' involvement together with professionals. I mean, this is something that for sure will facilitate uptake of tools such as Rebecca and others.
Thanks a lot, Marco. Really appreciate it. And I see that we had a question in the chat from Carmela. And Giannis, thanks for answering her. Carmela, did your question get answered, or do you have any follow-up? This was on the some aspects of the Rebecca 360 digital biomarkers, informed consents. Any additional questions, or are you covered?
Yeah, it's covered. And thank you very much. I really appreciate it. And this discussion has really enlightened my perspective. I come from an environment of randomized clinical trials. And here, what we are seeing is that, you know, patients and hospitals and communities treating people who are living with cancer, they don't exist in a vacuum. And as mentioned already, today is now probably the best moment to understand all these different ecosystems on how we can better prevent, treat, and understand not only the cancer, but those who are living with it and those who are caring. So many resources are now available. And in a way, this discussion, in a way, it makes me less afraid about all these digital tools. And that thing about the point about the trust, I feel it's so important in order for us to move forward in this field. So thanks to the Rebecca team and to all the speakers.
Thanks very much, Carmela. Appreciate it. Inger, I see you have your hand raised. Do you have a question?
Yes, because I think Camilla and also Marco point out some very important, also Magda, trust from the patient. It's the patient and the person who are diagnosed with breast cancer who are under, who's the, how to say, the center of what we are doing. So therefore, I think trust is very, very important. And therefore, I also would say that I think it's very important. It's very interesting to listen and to hear what you have managed in the Rebecca study, but I also think that if you are going to include this in clinical daily practice, it's a long way to go in order to take one step at one time, and in order to see what do you want to start with, because we are in clinical daily visits, and we know how difficult it is to implement new things. It has to be attached to guidelines, and it has to be standardized, and it has to be trusted, and it has its cultural differences and so on. And the patient, yesterday a patient told me, wonderful, you look at me, because it's so many MDs who doesn't look at me as a patient. That this is some very, very important thing. And then this person, also a lady, said, in addition, I'm so afraid of going into the network because there I get too much information at present. So I think here we have to be very careful, take one step, but I think it's very important to have this new way of thinking and include new way of digital knowledge. So congratulations with that, but we have to standardize and think of the human resources and include it into guidelines step by step.
Thank you very much, Inger, for sharing your perspective and your comments. Anything from our panel of health authorities before I ask another question, or do we have other questions? Yes, Michael, please go ahead.
Yes, I totally agree with you, Inger. According to the trust, and closely connected to trust is how do we apply to the legal context and to the ethical context. Most of us have these ethical improvements, but in this context, perhaps it's also trust and what kind of data do we share from the platform into the system or to other systems, standalone systems perhaps. It could be both wearables of different kinds and so forth. And are we sharing personal data? Are we using pseudonymized data or anonymized data? How do they apply to the legal context of GDPR and so forth? It's important to have that in mind because it's part of the trust complex.
Absolutely, a really important point you're making here, Michael, and definitely I think we're seeing a theme emerge here in terms of trust with so much data coming through, and it's providing essential insights that are really game changers in terms of patient care, but also recognizing that there's a lot that needs to be considered and addressed in a deliberate manner as it's scaled up in a sustainable way. And so, looking to the health authorities, I'd also be interested to hear from you, going back to concerns or obstacles. We talked about those concerns or obstacles in a clinical setting, but also, do you see other obstacles that we haven't touched on so far in this discussion in terms of administratively, in terms of the digital breach that we talked about earlier, in terms of the other health managers in a system, or scaling up and making this sustainable long term? Is there anything else that comes to mind that you'd like to comment on?
If I may?
Yes, please go ahead. Thanks.
Continue. I think To put it this way, in my experience, vendors often has designed a very brilliant product and try to sell it into the clinicians. I would put it the other way around. It's really important, as I see it, as a really trusted and good need analysis has provide and proceed the different kinds of products that are to be supporting a specific ailment, condition, parameter, or whatever. That part is often lacking, I would say, and I think that's a barrier when coming to a clinical context and say this wearable is doing very well. You can use this for this and that, and a clinician may ask why. So the dialogue between the clinical expertise and the developers is extremely important, I think.
Absolutely. And I think, Javier, I saw your hand raised first, but as a clinician and a technologist, perhaps you have something you want to add?
Yeah, I mean, it's my reaction to what Magda said because I think it's really relevant because when we tackle this type of digital tools, we go to the technical bits, but then you have to redesign the workflow, and we've already commented on that. But I think something that we need to also tackle in general is the healthcare professional shortage. And repurposing of healthcare professionals and roles. So I think we are like in a role crisis, and we've touched upon on that in some of the interventions, but probably the roles of the MDs, of the nurses, of the admin staff, other new roles, physiotherapists, psychologists. I mean, there's a broad range of healthcare professionals that we need to adapt the system to these new roles. And when it comes to digital health interventions and digital health tools, this is very relevant because someone needs to monitor these dashboards that Rebecca has created. Who is monitoring that? Who is reacting to all the different indicators and alerts that this might generate? How we incorporate this into the guidelines, as this has been mentioned. Are the disease guidelines going to incorporate, if you've got this alert in this health outcome, you need to do this or that? So I think, as I think Inger said, we need to go step by step because obviously there's a lot to do, a lot to redesign, a lot to repurpose if we want to integrate this in the clinical workflow. And this is probably why we still don't see it in clinic because obviously this is very difficult to implement. But I think we are in the right path, and most of these things are solved when you have this participatory process or this human-centric design, participatory design, when you are developing these digital tools, because then you've got the perspective of all the important stakeholders, and this involves caregivers, this involves patients, this involves healthcare managers and healthcare professionals, so that then you can redesign the clinical workflows, incorporate it to guidelines, and then this will generate trust, as this has also been mentioned. I just wanted to add it like this, this focus on the roles, which I think it's relevant in this scenario.
Thank you very much, Javier. Yeah, I mean, it's, really good points, really important points in terms of the roles and taking a step-by-step approach, and absolutely the human-centered design. This was touched on by other speakers, but can't be ignored at all. It must be emphasized. It's about getting patient perspective, but also, as you said, caregivers and those different clinicians that are supporting the patient. So thank you for that. Marco, you were next.
Yeah, thanks, Alexis. Well, very quickly, I just wanted to add one little thing, because I mean I mentioned resources before more as a enabler. Sometimes it could be a barrier, but sometimes the resources are already there out there. The thing is that they are not like used efficiently, and maybe to level up a bit also the work that European projects do, because I mean, us as Euriga, we are involved in other projects. Rebecca is one of the best practice here to learn from. But how to ensure that those tools, those new technologies, approaches, frameworks in which like the clinical setting will be operating, or the healthcare system as a whole, are somehow speaking to each other. How to ensure that, I mean, we do not replicate efforts. How to ensure that, yes, that all these, let's say, pieces, let's say, go into the same puzzle, so we can leverage on it. And I think here, I mean, resources would be important also to identify to whom to speak and to whom learn from, and having this, let's say, mutual recognition and learning continuously to let's say level up also, and the upscale and sustainability of the project.
Thank you for that, Marco. And yeah, indeed, I agree. We can't forget about the resources, but also making sure that the puzzle pieces are fitting together. We're coming up soon to the end of our workshop. So Anastasio, I think you'll probably be our last to speak before I do a quick round table for final thoughts. So please, over to you, Anastasio.
Thank you. I will give you some insight from the side of Rebecca, as being one of the partners. Trying to answer the previous question, what is the obstacles and what is needed to be done in order to make it possible for adoption of this kind of systems in real conditions of hospitals. I have to say, first of all, that in Rebecca we tried to consult in all the way during the development of the system, both the clinicians and representatives of the patients. One of the participants in Rebecca is Amazona, and they played a very important role in designing the system. Amazona is a representative of breast cancer patients. The second main element that I want to bring is that Rebecca was a novel approach in producing data that we had to prove that they are useful in research and in patient management. So probably the most effort in Rebecca was to prove the concept of real-world data captured from sources that are not the regular sources of a hospital. They are coming from the online activity of the patients, and also from wearables and smartphones. So it was not trivial to prove that this kind of digital biomarkers that are produced are useful in clinical practice and also in clinical research. Of course, once we prove this, we also have to prove that it is safe to use this kind of systems, safe in all possible manners, and also it is privacy preserving. So we had to in my opinion, Rebecca is a first step in an attempt to prove to the medical community and also to the patient community that these tools are useful and can be integrated in the practice. It would be probably a second step after the end of the project to develop all the to enhance all the required infrastructures and connections with real stakeholders in order to solve the standardization problems, to solve the adoption problems, to find the ways for financing this kind of systems. Thank you.
Thank you very much for that additional information. It's very helpful, and I appreciate that. Before we close for the day, I would just like to turn it back over to our 4 guests for any final thoughts, comments, or reflections you've had over the course of this hour and a half together. Let's start with Professor Gabrielli, and then after that we'll go with Michael and Marco and Javier.
Okay, thank you. Just my last comment. I would like to comment on the relationship between regulations in the field of digital health and medical research in the same sector. I think that publishing shared regulations at national and better at European level is an excellent strategy to promoting the correct and in a certain sense uniform use of digital data, and promoting digital health in everyday activities. But I also think that regulations are not the right tool to managing change in the medical approach to clinical practice. This is simply because the rules can give the technology change, but diseases do not conform to rules. They are anarchic and therefore changeable, both horizontally and vertically. And so I think that we must learn to use the digital technologies to study human beings better than we have done so far. And as a consequence, patient trust does not come from technologies, but from the healthcare professionals who use them and recommend them. And but to do that, first of all, the healthcare professionals have to trust in the technology, digital technology use in daily lives. So that is the panorama, the horizon that we have to face in front of us, I think. Thank you.
Thank you very much for that, Professor Gabrielli. Really appreciate it. Over to you, Michael.
Thank you. Thank you for this session, indeed. I think one of the most important things to take as a departure for the next step when integrating or developing this kind of tools for the integration point of view, create a multi-professional team. And this multi-professional team should be representative for the professions that will be included in the practice work when using this device. If this is done, why should it be used and how should it be used? That are the most vital questions to be discussed around. And then the final part of this is the trust. Again, the trust for the patients. See the patients as they are using this for their own benefits, not preservably for the clinician's benefits.
Well, I don't think so.
Thank you very much. Thank you, Michael. Marco, over to you for final thoughts.
Yeah, thanks, Alexis. I'll be very quickly because in terms of takeaways, I mean, I fully agree with what already Michael and Professor Gabrielli already said. I mean, but more concretely, as takeaway, I will bring the Rebecca experience to our network of implementers, let's say. So I think that this is like a first touch base of let's say engagement between Rebecca and our network, and I'll look forward to let's say continue this exchange, also to promote the tools that the project have been developing to our network of regions. So let's say the project is my takeaway of today.
Thanks very much for that, Marco. And last but not least, Xavier.
Yeah, very short. I mean, it was very insightful. I think we've already mentioned the key takeaways. I will just congratulate the team and also encourage that this type of projects are the what the European Commission is actually funding. So we need this multidisciplinary, multimodal data type of projects so that we can develop the future healthcare management and shape the healthcare policies according to these new tools that we are already seeing in research.
Fantastic. Thank you very much. Well, I see we are at time, and I just want to give a huge thanks to our esteemed guest for being here today, for generously giving your time to share your expertise and your perspectives on the Rebecca project. So thank you, Marco, Xavier, Michael, and Professor Gabrielli so much. Thank you also to Yanis and the Rebecca project coordinators, and of course, my colleagues at EMA for working diligently behind the scenes to make this workshop happen. I thank you very much and wishing you all a very good rest of your day. Thank you.
Thank you. Bye.
Thank you very much.
Thank you very
Thank you.
much. Bye.
Thank you. Bye-bye.
Thank you. Bye.